Thank you so much, everyone, for joining us tonight for Cases in the Community, where we discuss available research guiding the care for our patients with urothelial bladder cancer. This is a part 3 of 3 CME series held in conjunction with the 2023 ASCO Genitourinary Cancer Symposium. And for the next hour and a half, I'm going to be channeling Neil Love so that we can educate one another and really take better care of our patients. It's a true pleasure to be here tonight, and I am joined with an illustrious faculty I'm sure you all know. My name is Dr. Elisabeth Heath, and I am a medical oncologist out of Detroit, Michigan. And I'm joined tonight with Dr. Matthew Galsky, who is professor of medicine with all of those lovely titles, followed by Dr. Jonathan Rosenberg, who is at Memorial Sloan Kettering, and Dr. Arlene Siefker-Radtke, who is at MD Anderson in Texas. But for tonight's purposes, we're amongst friends, and we have decided to call each other by our first names so we can make this as interactive through your iPad and through the webinar as much as possible. So thank you so much for being here, and thank you also for the wonderful commercial support, which we could not run this program without. The next set of slides are our disclosures. So I think we're ready to kick it off. Our goal tonight is to try to cover 4 main topics, and as many of you know, the field of urothelial or bladder cancer is just exploding all around us, as seen by the sessions today, and it's getting a little bit complicated. So my colleagues and I are going to do this in 4 modules. The first one will be to integrate novel treatment strategies so that we can also focus on non-metastatic and non-muscle invasive bladder cancer. Then we'll proceed on to talk about current and future plans for frontline therapy, followed by selection and sequencing of these therapies. And then I'll finish this off this evening talking about novel investigational agents that are in clinical studies. I also want to thank our community oncologists who have been so gracious with their time, providing us these really important questions that plague all of us in practice. So you will see them tonight on video, and they will share some of their cases and their experience, and then we will go through some of their challenging cases and see how we would answer them in our own practice. All right, so we're going to go with the first case.
Good evening, everyone. I'm Neil Love from Research to Practice, and welcome to our real-world case library. Tonight, focusing on the management of urothelial bladder cancer. We begin with a 79-year-old man with BCG-resistant non-muscle invasive disease, a patient of Dr. Sunil Gandhi, who after 2 doses of pembrolizumab ended up intubated in the ICU with COVID.
Past medical history, diabetes, hypertension, hyperlipidemia, atrial fibrillation, ECOG performance status of 2. I don't think he can take radical cystectomy. So we started on Pembro, did well with Pembro, but then 2 doses later, he had severe COVID infection. What I don't know, to be honest still, is Pembro increases risk of COVID infection. He restarted Pembro after that, little incompliant, but still in remission. I have 3 patients. Fortunately, my 3 patients have responded. And this patient, how long I continue Pembro? I haven't had any other patient where there is bilateral ureteral involved. How common is that?
So the topic is checkpoint inhibitor monotherapy and other alternatives in BCG-resistant non-muscle invasive disease. In addition to sharing your clinical experiences, please also address the issue of duration of treatment with an IO and the specific issue, as in this case, of bilateral ureteral involvement. And finally, the question of whether IO treatment in any way affects the risk and severity of COVID infection.
Oh my goodness. Well, I think many of us probably have very similar type patients that undergo this because we know the growing role of immunotherapy. Matt, what are your thoughts here on immunotherapy, especially like this patient, in non-muscle invasive bladder cancer?
So I think we'll talk about some of the data supporting that a little bit more. But the case that's described is one that I have to say is similar to patients that I've seen over the past couple of years referred for treatment with immune checkpoint blockade, specifically patients with bilateral upper tract disease, because in that situation, of course, there's limited options. So it's not that common, but of course we know patients with urothelial cancer in one location in the urothelial tract have a higher risk for other urothelial cancers, and this does come up from time to time.
Yeah, absolutely. And Jonathan, we've had many patients who've tried to make associations with some of the side effects, perhaps increasing the severity of COVID. Any truth to that kind of question or line of thinking?
I don't think there's tremendous amount of truth there. There is data from my own institution where they looked at outcomes of patients getting immunotherapy, and it seemed that the lung cancer patients were the ones who did the worst, but they had multiple pulmonary comorbidities to begin with, and probably was more to do with the heavy smoking history rather than the immune checkpoint blockade. And other cancer types did not seem to have severe outcomes with COVID. You obviously would prefer not to have COVID while you're on immunotherapy, but
right.
I'm not sure it makes it worse.
No, I think I agree with you there. And Arlene, the other question that always comes up, I think this happens a lot in tumor board, is how long do you continue? Let's pretend the COVID issue wasn't an issue. Would you just keep going with pembrolizumab for the non-muscle invasive?
Well, if you look at the trial data, it does suggest that we don't give it forever. And I can say, as we treated metastatic patients in the day where we had trials where we gave it forever, we saw immune toxicity occur in a large number of patients as they got beyond that 3 to 4 year mark. So I would typically follow the approved strategy, giving that 2 years of pembrolizumab in the setting of a non-muscle invasive bladder cancer, trying to provide control as long as one possibly can.
That's terrific. Thank you so much. And we'll move on now to the next case.
The next case is presented by Dr. Ranju Gupta.
This is a guy who had T2N0 high-grade papillary muscle-invasive bladder cancer, and he had neoadjuvant chemotherapy with 4 cycles of gemcis, had cystectomy done, and still had residual disease. We initially did not recommend any adjuvant treatment, and then the Checkmate 274 came, and I was able to get the approval, and we just started him on adjuvant nivolumab. He just received his 2nd cycle last week. He's doing great. So my question here is, would this be the right patient to do the adjuvant nivolumab? Would you do it in every patient or only in those patients who are PD-L1 positive?
Before considering questions related to this case, let's just bring one additional one, a patient of Dr. Swati Vishwanathan.
He's 80 years old, had hematuria, had a CT showing some soft tissue mass at the left renal pelvis, had a cystoscopy with biopsy of the left renal pelvic mass, which was concerning for high-grade urothelial cancer. In clinics where urologists and oncologists see the patients together, for high-grade urothelial cancer, are they preferring to do neoadjuvant versus adjuvant chemo? This patient saw me after surgery, T3N0 disease. His GFR is 40, he's 80 years old. I offered him gem-carbo based on the POW trial. But the other option I gave him was nivolumab for 1 year. He's still trying to think what he wants. He does have psoriasis, so he's concerned if nivolumab will make that worse.
The specific questions about the cases are, first, from Dr. Gupta, in what situations do you recommend adjuvant nivolumab in general for patients having surgery? And what about patients who are getting neoadjuvant chemotherapy? From Dr. Vishwanathan, how do you decide whether to use neoadjuvant therapy in high-grade urothelial cancer in the upper GU tract? What about adjuvant chemotherapy or immunotherapy? How does a prior history of psoriasis affect the potential use of immunotherapy?
And right off the bat, I think that question of psoriasis is one that plagues a lot of us. Maybe it's that or some other autoimmune issue. Arlene, what are your thoughts there, talking at Dr. Vishwanathan's question? Would that deter you from even offering immunotherapy in this case?
Well, there certainly is a risk that psoriasis could worsen. However, many of the clinical trials allowed some autoimmune conditions, such as psoriasis, to go on treatment. And when you think about it, it really becomes a question of whether the benefits are outweighing the risks. So in a patient with psoriasis that perhaps is controlled with topical therapies, I think it would be very reasonable to give an immune checkpoint inhibitor. Now, if a patient has a severe condition affecting other organs, requiring systemic therapy, then such as systemic steroids, systemic infliximab, TNF-alpha blockers, those are the patients that probably aren't going to do well with immunotherapy, and I would not consider a checkpoint inhibitor.
That's a great and useful way to think about how to help our patients. Jonathan, what are your thoughts about what to do about upper tract? And I think many of us have those patients where sometimes it's not as clear cut. How would you offer sort of next steps with that?
I just want to make a comment about IO use with immunotherapy, with autoimmune disease first. So I may be a little more of a cowboy about it, but if their disease is well controlled, they have a life-threatening condition, and the patient understands that it's probably going to get worse, I haven't shied away from using it. And sometimes you really get burned, and other times you are very pleasantly surprised that the autoimmune toxicity doesn't get worse, and you have great responses. And so I've used it in patients with colitis. I've used it in patients with rheumatoid arthritis on biologic modifying agents, often with flares. But it's a risk-benefit discussion. In an adjuvant setting, I might not use it, whereas in a metastatic setting, I might. So for upper tract, neoadjuvant, I favor neoadjuvant chemotherapy in cisplatin candidates because they're probably not going to be cisplatin candidates after you take a kidney out. And our criteria are high-grade upper tract disease with visible mass in the upper urinary system. And we may or may not have muscle invasion. We offer neoadjuvant chemotherapy for those patients, but if they go to the OR first and we see them afterwards, I think then it's this complicated discussion around adjuvant gemcarbo often with some benefit based on the POUT trial, probably not as much as cisplatin. And the data from Checkmate 274 in this upper tract subset wasn't as robust in favor of nivolumab. And so, you're sort of choosing between two options that you may not feel have dramatic benefit.
Well, and Matt, I wonder then, just as Jonathan was mentioning adjuvant nivolumab, for Dr. Gupta's patient, I think the person was a T2. Would you have offered that? Or do the trials support that approach?
So the inclusion criteria for Checkmate 274 included patients who had received neoadjuvant chemotherapy and had residual T2 or higher disease, or T3 or higher disease in patients who couldn't receive adjuvant cisplatin-based chemotherapy. For a patient who has residual T2 or higher disease after neoadjuvant chemotherapy, it would be appropriate.
That sounds great. And just, as we're finishing up, how long would you continue that treatment?
So per the study, up to a year of treatment in the absence of progression or prohibitive toxicities.
That sounds terrific. Thank you so much. I think we can actually then move on to your talk, Matt, which is really focusing in on these novel strategies of non-metastatic bladder cancer. So take it away.
Thank you. So I'm going to try and cover early stage disease in pretty quickly because there's lots going on in this space. So I'm going to talk about non-muscle invasive bladder cancer, which I think everyone in the audience knows really comprises these three entities: papillary tumors that are non-invasive, carcinoma in situ and T1 disease invading into the lamina propria, and then muscle invasive disease as well. So BCG unresponsive non-muscle invasive bladder cancer has been a hot area for drug development. BCG has been around forever. It works well. But when BCG doesn't work or stops working, that's been a problem historically because the standard of care has been radical cystectomy. And so this has been a hot area for drug development. Part of the challenge to drug development in this space historically has been a very simple one that we've faced in other clinical disease states, just a matter of defining things. You can't study things if you don't define them consistently. And so who was BCG unresponsive and who should be enrolled in trials in this space was challenging historically, and then groups got together and really defined this entity, and this definition has really been carried forward and used for eligibility criteria. There are 2 FDA approvals in this space, and probably more coming, but 2 in recent years. One is pembrolizumab, and the other is nadofaragene. Pembrolizumab you all know about. You might not know quite as much about nadofaragene. This is a gene therapy. This is a replication-deficient adenovirus meant to express interferon alpha-2b. So let's look at the data supporting these approvals. This is the KEYNOTE-57 study. This is pembrolizumab for patients with BCG-unresponsive non-muscle invasive bladder cancer. 2 cohorts of patients were enrolled on this study, and this tends to be the case for non-muscle invasive bladder cancer studies. And for the medical oncologist who might not see this entity as commonly, just to sort of wrap your heads around why there's 2 cohorts, carcinoma in situ is something that's visible and usually diffuse and not surgically resectable completely. So endpoints in carcinoma in situ are response endpoints. You give a treatment and you see if that cancer disappears. For papillary disease, though, that's similar, that's analogous to oncology trials in later stage that are adjuvant trials. So there's a lesion, it's resected, there's nothing to see, and so you have to rely on time to event endpoints. And so those cohorts are usually separated out for that reason. So KEYNOTE-57 led to the FDA approval of pembrolizumab in BCG-unresponsive carcinoma in situ based on the results of KEYNOTE-57 in the cohort enrolling those patients. And you can see here the 3-month complete response rate was 41%. In this Kaplan-Meier curve are the patients in CR, and you can see this drops off over time and then maybe stabilizes a bit. So keep that in mind, 3-month CR rate of 41%. Today, just a few hours ago, the papillary cohort was presented for the first time, and that showed that the 12-month DFS rate was about 40% as well, slightly more than that. So, interpreting results in that space, of course, complicated in the absence of a control arm. This is the phase 3 trial of nadofaragene. Again, 2 cohorts, and this study reported both cohorts simultaneously, so this is reported in Lancet Oncology, and you can see in patients with carcinoma in situ, the 3-month CR rate's 53%, so maybe slightly higher. And then you see the high-grade TA or T1 cohort, 12-month disease-free survival is 43%. So these treatments are starting to look somewhat similar in terms of the activity. Of course, a difference is when you give a drug into the bladder versus systemically, you don't have systemic side effects when you give a drug intravesically historically, and that's seen with nadofaragene. The next space that I want to cover is muscle-invasive disease, and we have 3 studies in the adjuvant setting exploring immune checkpoint blockade. Checkmate 274 exploring Nivo versus placebo and leading to FDA approval of nivolumab. The disease-free survival, or the endpoints from the study, were updated today. They were initially reported with 5.9 months median minimum follow-up, and today reported with 31.6 months minimum follow-up. And you can see here that the DFS endpoint favoring nivolumab is really kept quite a stable hazard ratio over this extended duration of follow-up. And this just summarizes the efficacy outcomes over time from 5.9-month minimum follow-up to 31.6 months. You could see the hazard ratios across endpoints in the intent-to-treat population in the 0.7 range, and in patients with PD-L1 high-expressing tumors in the 0.5 range. Moving to the neoadjuvant setting, we have a unique situation in bladder cancer where we have patients who are cisplatin eligible, in which case novel treatments generally have to build on chemotherapy, but we have cisplatin ineligible patients where novel treatments could be studied by themselves prior to surgery. And so there have been a number of phase 2 studies exploring neoadjuvant immune checkpoint blockade, either single agent or doublet immune checkpoint blockade. Pathological complete response is is a readout of activity of novel agents in this space. And you could see the path CR rates with immune checkpoint blockade really rival what we see with chemotherapy. It really between the 30 to 40% range in these studies. And so this has led to the launch of several phase 3 studies exploring neoadjuvant immune checkpoint blockade in patients who are cisplatin ineligible, where historically going straight to surgery has been the standard treatment. And you'll hear more about this from some of our other speakers, but immune checkpoint blockade plus the antibody drug conjugate enfortumab vedotin have been integrated into these studies based on the activity of this regimen in metastatic disease. Building on chemotherapy with immune checkpoint blockade, we have a number of phase 2s in the neoadjuvant setting in that space as well. And maybe we're seeing path CR rates that are slightly higher than we see with the single agents, maybe a little bit more in the 40 to 50% range versus the 30 to 40% range. And these have also prompted phase 3 studies comparing chemo, GemCis, with immune checkpoint blockade versus GemCis, and there's adjuvant portions to these studies as well. So we don't have readouts from these phase 3 studies, and these will be forthcoming in the next few years. I'm going to switch for the last 2 minutes to some very novel strategies in this space, and one of these is really based on a technology solution. And I think for the medical oncologist, this is probably off your radar a little bit, but this is TAR-200. This is a drug delivery device that's inserted into the bladder, assumes this pretzel shape so it stays in the bladder, and then it releases gemcitabine through an osmotic-driven gradient in a continuous release fashion. And so this was studied in a pilot phase 1 study showing feasibility in the pre-surgical setting. And intriguingly, there were pathological complete responses just putting this gemcitabine pretzel into the bladder. So that led to this concept, well, if path CRs are occurring, then does the bladder need to be removed? And that led to this pilot study where patients who really weren't great candidates for surgery received TAR-200. And you can see in these swimmer lane plots, this is pilot data, but certainly some patients have sustained disease control with this approach, where the alternative really would have been cystectomy, or of course chemoradiation is an option as well. So there are a number of studies integrating TAR-200 now, from the non-muscle invasive disease setting for BCG-naive non-muscle invasive bladder cancer to the muscle invasive setting, comparing TAR-200 with immune checkpoint blockade versus chemoradiation, really trying to add yet a third pillar of treatment for muscle invasive bladder cancer. And then in muscle invasive bladder cancer in the neoadjuvant setting, single agent immune checkpoint blockade versus TAR-200 plus immune checkpoint blockade. In the last few seconds, just sort of building on that approach, can we devise risk-adapted strategies so that we don't have to take patients to cystectomy who are having a great response to systemic therapy? 2 studies that were presented today, this one with chemotherapy plus immune checkpoint blockade, where patients in a complete clinical response were offered the opportunity not to have their bladders removed. Here are the swimmer's lane plots. The dark lanes indicate patients who have had no recurrence and an intact bladder, and the light blue indicate patients who've had local recurrence followed by cystectomy, and the arrows at the end indicate patients are still alive. So some feasibility established for this approach, and then a similar strategy trying to make these treatment decisions based on molecular profiling of the primary tumor in addition to clinical response assessment. So these are not standard of care approaches, but these sorts of approaches are coming as we think beyond traditional chemoradiation or neoadjuvant chemotherapy followed by cystectomy for muscle invasive bladder cancer.
Thank you so much. And I just want to highlight, I think all of these discussions now really stress the point that we need multidisciplinary care even in the non-muscle invasive setting. And that's probably, getting tweaked all around the country, but something that we really need to pay attention to. We're going to move forward to now the next module, and I think it's time for a video.
The next 2 cases reflect first-line treatment of metastatic disease. The first is a patient of Dr. Paul Markowski, a 75-year-old man with bulky retroperitoneal adenopathy and a 2.5 by 3 centimeter liver lesion which on biopsy was confirmed to be urothelial carcinoma.
So he was treated with gemcitabine and cisplatin. He was then started on maintenance of avelumab and had been doing well with it, but now he's getting up to close to a year and still having a good response to his avelumab, but increasing fatigue, some arthralgias that do seem to get a little better when we start him on a little bit of steroids. So my main question is, how long do we continue the maintenance of avelumab?
Dr. Gigi Chen also has a patient requiring first-line treatment for metastatic disease, but with several additional challenges.
This is a 52-year-old male. He has a history of ulcerative colitis, and he had undergone BCG induction and maintenance. But in October of 2022, he presented to the hospital with seizure, and a CT scan of the head showed multiple brain metastases. He underwent neurosurgery. Pathology from that was consistent with urothelial carcinoma. He did complete whole brain radiation because he had multiple brain metastases. So a couple of my question is that normally I would be considering chemotherapy followed by immunotherapy as a maintenance, but given his ulcerative colitis, is immunotherapy completely contraindicated, or are there ways, to still consider giving him immunotherapy?
So it seems a little unusual to go from non-muscle invasive disease to multiple brain mets.
It is. During the COVID pandemic, there was a quite long period of time that he did not follow up. So this may be part of, what we see.
So in summary, Dr. Markowski wishes to know about the practical duration of maintenance of avelumab, and Dr. Chen is interested in the optimal first-line systemic treatment in a patient presenting with brain metastases. A secondary query from Dr. Chen is about the use of a checkpoint inhibitor in a patient with a history of ulcerative colitis.
Well, we've already heard from Arlene and Jonathan their thoughts on autoimmune. Matt, I'm going to you. Here's a person with ulcerative colitis where I think if we saw that in our own practice, we would worry a lot more. What are your thoughts? Would you proceed ahead, or is that not advisable?
Yeah, I certainly worry about it as well, but I find that, colitis, as opposed to some of these other diagnoses, there's oftentimes a very unclear history of colitis, and someone's been told they've had colitis 20 years ago, never been on meds for it. The diagnosis is not definitive, and so if there's a question about the diagnosis, of course, I would have a patient see a gastroenterologist to try and clarify that, given the implications of that decision. But yes, if there's really active colitis on meds, then certainly a more conservative approach is warranted, depending on the situation and the risk versus benefit.
Yeah, thank you so much. And Jonathan, I think we've all experienced the delay in care and follow-up due to COVID. Unfortunately, this person developed brain metastases. Would that guide you in selecting your first-line treatment?
It obviously depends on what sort of brain-directed therapy they've had and need. With multiple brain metastases, unfortunately, the outlook is very poor no matter what you do, probably. I probably, if they were fit and neurologically intact, I would probably favor chemotherapy rather than upfront immunotherapy, because my experience has been very poor using upfront immunotherapy in these situations, but there isn't an optimal first-line treatment. Nothing really gets into the brain very well. The immune drugs don't. Chemotherapy doesn't. I'm curious to hear what other people might say.
Yeah. Well, Arlene, how would you proceed? Also similarly?
Yeah. Well, I think it is a challenge when we have brain metastases. We don't have optimal strategies in that setting. I think we would typically, if it's a couple spots, we would aim for stereotactic radiation to provide control. And I have favored therapies like even Docetaxel, methotrexate does cross the blood-brain barrier, so maybe you get a little activity, but the truth is patients with brain mets still do rather poorly. I've overall seen some impact with the use of immune checkpoint inhibitors, providing some control in patients with brain mets. So if they did make it through their stereotactic radiation, then some systemic chemotherapy, I might favor Docetaxel. I would then follow that up with an immune checkpoint inhibitor, if of course they live long enough to get all three of those.
Now, that sounds great, and I guess I'll ask you as well for Dr. Markowski's patient, how would you sort of approach the length of time for avelumab? I think we've all had patients where they're kind of doing great for a year. Would you stop? Would you keep going?
So I think, again, there's a bit of that whole risk-benefit analysis. I think the trial did give up to 2 years of treatment. If a patient's in a complete response, then one certainly could feel comfortable taking a break from an immune checkpoint inhibitor, giving that period of time off, especially with the sense that over time, if patients continue, they are likely to develop an autoimmune condition over time. But if you have a patient with a partial remission, or maybe they have liver metastases and still have visible disease, I've even sometimes employed a biopsy confirming there's active disease. I'm a little more inclined to continue. I don't know whether that's right or not, but clearly it does appear to be providing some control.
And I know we probably have no good time to talk about this, but sometimes our definitions also in helping us decide the chemotherapy or no chemotherapy is this verbiage of cisplatin ineligible, platinum ineligible. Jonathan, do you want to just clarify for the group, what are the definitions you're going with to sort of put people in those buckets?
For patients who are cisplatin ineligible, it really is based on renal function, hearing loss, and peripheral neuropathy for me, and potentially cardiac issues with CHF. And then platinum ineligible patients are really all of those and more. Poor performance status, it's a very poorly defined patient population. In fact, there really isn't a standard definition for platinum ineligible patients. And there's very little prospective data actually with that. There is a drug approval in that disease state, but we don't really have a definition for it at this point.
Thank you so much. I think now we'll move on to the next case.
The next case is from Dr. Spencer Bachow, an 82-year-old woman with an interesting prior history.
I didn't know her at that time, but she had bilateral hydronephrosis and had double J stents placed. She did not get neoadjuvant chemotherapy. She was referred down to a urologic oncologist. They opened her up for surgery and they found tumor completely fixed and immobile, and it was unresectable. She underwent 6 cycles of dose-dense MVAC, and she tolerated it well, apparently, and attained a complete remission. She started developing some pain in her abdomen. She had a CT scan that showed a 6.2 centimeter omental mass. So my question for the expert is, how do you choose between gemcitabine and carboplatin followed by avelumab maintenance versus immune checkpoint inhibitor monotherapy? Another question is, for patients on avelumab, have you seen a lot of arthralgias in patients that are receiving avelumab maintenance with bladder cancer, arthralgias and infusion reactions? The few patients that I've had on it have developed terrible arthralgias, and a lot of them developed pretty significant infusion reactions to the drug.
So Dr. Bachow's questions about this case are, first, how would you manage a patient who had a CR to dose-dense MVAC for an unresectable urothelial bladder cancer followed by disease relapse? Have you observed arthralgias on avelumab? What about infusion reaction? How are these prevented and managed?
These are such real-life issues that we all have to contend with. Matt, from this particular situation, what would you recommend for this patient who had a CR on dose-dense MVAC?
So this patient had clinical T4B disease, primary unresectable disease because the tumor was fixed. This is an 82-year-old woman who got dose-dense MVAC and sounds like tolerated quite well and had a great response. So I think really on the table here is what to do for local therapy. That would be standard. So is this patient a candidate for cystectomy? You might balk at that in an 82-year-old patient, but again, this patient received dose-dense MVAC. So I think that's on the table, and then consolidation with radiation would be on the table as well. We discussed the data about clinical complete response and what that means. And of course, I don't think we're quite ready to not do local therapy in all patients in a situation like this.
Yeah, Jonathan, how would you sort of help with these arthralgias? Do you see arthralgias in your patients getting immunotherapy?
I definitely do. For many of the patients, it appears to be an autoimmune phenomenon similar to rheumatoid arthritis and its manifestations. I employ my friendly neighborhood rheumatologist to help me out. This is not a toxicity that goes away quickly. It can take months to a year, even after you've stopped treatment, to really go away and stay away without immunosuppression. On the other hand, for patients who are getting good responses, we've actually treated through it and put them on disease-modifying agents, and they've done very well in many cases, but sometimes it's not manageable.
Yeah, how about you, Arlene? You're seeing that?
So I have seen some of these arthralgias, and as Jonathan mentioned, they can appear in a rheumatoid arthritis type pattern, and even seeing high IL-6 levels. I have used tocilizumab, which is one of those IL-6 binders, and it shouldn't impair the immune response significantly. And I've had patients who felt almost crippled from their arthralgias. They went on steroids, would get better. The moment they paused the steroids, it would be worse. We put them on tocilizumab, great response, walking again, and we were able to continue the immune checkpoint inhibitor.
Go ahead, Matt.
So just one point, that in situations like this, of course, the diagnosis that you don't want to miss is a PMR like immune-related side effect, because that's fairly easily managed with low-dose steroids.
Yeah, absolutely. And I think the other sort of issues is just the practicality of when you give these types of medicines, the infusion reactions, your staff, everybody has to be aware. Is this something that you think we're getting better at, Matt, these days? Or do you think we're still sort of learning as we go?
I think we're getting better at it.
Yeah. I know one of the questions is sort of how do you surround yourself with multidisciplinary care in addition to perhaps the rheumatologist? Arlene, who else do you involve in the person's care?
Well, it really depends upon the toxicity. And rheumatology can be very helpful with these autoimmune conditions and helping make these diagnoses for the colitis, the gastroenterologist, or their help with hepatitis, neurologist for these unusual neuropathies and Guillain-Barré. So we're really seeing a whole host of unusual autoimmune disorders that require that multidisciplinary care across the whole medical board.
Yeah, absolutely. So I think that theme is resounding. We just need to make sure everybody's at the table to optimize the patient's care. We're going to listen to you now, Jonathan, and listen and learn about some possible frontline strategies.
So I'm going to update you today on the current and future, what we think are the future frontline strategies for the treatment of metastatic urothelial cancer. And as you've heard, at this meeting and previous meetings, there have been dramatic changes in the treatment of advanced urothelial cancer in the last several years. We've seen the dramatically reduced role of immune checkpoint blockade as initial therapy, maybe not first-line therapy, but initial therapy, and the emergence of maintenance avelumab as a new standard for patients with good responses. We've had a series of negative trials, phase 3 trials, combining immune checkpoint blockade and chemotherapy, although there's still one or two that have yet to be reported. And we're seeing a lot of interesting things now with immune checkpoint blockade plus antibody-drug conjugates and ADCs. So one of the initial drug approvals for first-line pembrolizumab in urothelial cancer was based on KEYNOTE-52, and this is the most recent data that's been published, showing that there was a higher response rate and overall survival if you had high levels of PD-L1. But initial approval for this drug was in any cisplatin-ineligible patient based on this single-arm trial. We saw, though, to our surprise, that in KEYNOTE-361, chemotherapy with or without the addition of pembrolizumab, that in fact, the addition of chemotherapy to immunotherapy did not provide a benefit, either in PFS or OS, in this randomized phase 3 trial. And we also saw, perhaps even more to our surprise, that the PD-L1 positive patients receiving pembrolizumab monotherapy compared to chemotherapy did not do better. The hazard ratio was 1. At the long-term outcomes, perhaps similar to slightly favorable. In the ITT population, also no benefit for pembrolizumab in the first-line setting. And so this initial data led to the label restriction to PD-L1 positives based on the early deaths seen with monotherapy, with immunotherapy. And then eventually these negative trials led to the elimination of the label for cisplatin-ineligible patients. And so at the moment, the only first-line checkpoint inhibitor that remains FDA approved is pembrolizumab for the so-called platinum-ineligible population, people who people who are not candidates to get carboplatin. It is a modest-sized population, generally very elderly patients, people with many comorbidities, really poor performance status that might not be related to their cancer. There's various definitions, no consensus. There was one published prospective study that we did with durvalumab as a control arm in a randomized phase 2 study. And you see the outcomes are, I would say, not spectacular. On the other hand, we really need an option for patients who can't tolerate chemotherapy, who initially present with advanced disease. We saw updated data today for the investigators from Vigor 130 showing that there was no improvement in OS with atezolizumab added to chemotherapy, and the drug was voluntarily withdrawn from the market for first-line therapy of advanced urothelial cancer. Based on the data from Vigor 130, they did not meet the co-primary endpoint of overall survival. Interestingly, though, in the hierarchical analysis, they never actually got to prove to statistically analyze this endpoint for the monotherapy versus chemotherapy, but did seem to suggest that for PD-L1 positive patients, there was in fact a benefit of immunotherapy compared to chemotherapy, and we saw data today, specifically in the cisplatin ineligible patient population, that in fact patients seem to do better. But atezolizumab no longer has an indication in the first-line setting based on FDA data. Of course, you've heard several times this evening already about avelumab maintenance therapy. This is the Javelin Bladder 100 study. This is, I believe, updated data showing a hazard ratio of 0.69 for patients who receive avelumab if they've had a response or stable disease, improved outcomes, substantial improvement in overall survival. This appears to be amplified in PD-L1 positive patients, but I think the benefit exists regardless of PD-L1 status and is broadly used. And the long-term data actually published in ASCO this past year, confirms this data and shows that these responses, while the curves may be slightly coming together as time goes on, still are maintained many months down the road for patients. And even at 3 years, you have about a third of patients, a little more than a third of patients alive. One of the questions that comes up very often is whether or not if you have a complete response, should you give a patient avelumab maintenance therapy, and I think that these data from the trial with OS on the top and PFS on the bottom suggests that in fact even if you have a complete response, this is an aggressive cancer, most of those responses are not durable and patients should get maintenance therapy, and the benefit is across the different subsets. I'm going to switch gears and talk about enfortumab vedotin, which is an Nectin-4 targeted antibody drug conjugate linked to monomethyl auristatin E, or MMAE, which is now FDA approved in the second and third line setting. It was recently shown in 2 cohorts of EV-103 to have very high response rates compared to conventional therapies, 73% in cohort A in dose escalation, published in JCO. And then at ESMO, reported the data for cohort K, which is randomized to EV and EV Pembro, non-comparative trial. EV Pembro here showing a response rate of 64%. 97% of patients had tumor reduction, which is sort of an unheard of number in bladder cancer. The progression-free survival and overall survival remain immature, but are quite convincing at over 20 months for EV and Pembro. PFS is not reached, and the duration of response are not reached either. And so 2/3 of patients were responding still at 12 months. Again, much better than we might expect to see with chemotherapy. I wouldn't pay too much attention yet to the shape of the curves. I think you'll see coming up at other meetings and further data and further follow-up that will really help us understand the outcomes. Enfortumab and pembrolizumab are not without their toxicities. Fatigue, peripheral sensory neuropathy, alopecia, and rashes were the most common toxicities. There were severe events as listed on the right, and including 5 deaths on study, 3 with EV Pembro and 2 with EV monotherapy. There are particular toxicities that are considered adverse events of special interest with enfortumab, and these are skin reactions, peripheral neuropathy, and hyperglycemia. Ocular disorders really were not increased significantly, and no high-grade events, but there were more skin reactions with EV Pembro than you had seen with either EV mono or pembrolizumab. Peripheral neuropathy, though, does remain the most common reason for treatment-related discontinuation. And unfortunately, it's often a sign of success that patients are on treatment long enough to actually get peripheral neuropathy over time due to the success of the therapy. I'd like quickly to also talk about some interesting data in the first-line setting for cisplatin-ineligible patients. This is early data from the Norse trial, which is a trial randomizing patients with FGFR3 alterations who are cisplatin ineligible to erdafitinib or erdafitinib and citrilimab. And this study only reported a very small number of patients, but showed a response rate of 68% in patients treated with a combination of erdafitinib and citrilimab. Most of these patients tend to be PD-L1 low. Most of these patients we think may not have great response rates to immune checkpoint blockade, although that is not totally clear. And so this is provocative early data. And it's similar to the data that we saw with a very small trial of regorafenib and atezolizumab, which had a 58% response rate in patients. Almost all of them were PD-L1 low. In regorafenib is an FGFR3 inhibitor that's investigational, that is probably not being further developed, unfortunately. But we saw here that highly active in this patient population. So in summary, first-line platinum-based chemotherapy still is the standard. That may change in a few months if EV pembrolizumab receives accelerated approval for cisplatin-ineligible patients. Maintenance of avelumab following platinum chemotherapy response or stable disease is now standard, and EV monotherapy is really a second or third-line therapy currently, but may move up to the first-line setting. And I'm particularly intrigued by the combination of FGFR inhibition and checkpoint inhibitors for future investigation. Thank you.
Thank you so much, Jonathan. I think lots of different combinations are jockeying to get first in sort of platinum or cisplatinum ineligible patients. We have a question from the audience about the length of maintenance for avelumab, Arlene, in terms of, does it matter if you had a complete response, a partial response? Do you care, or do you just give it?
Well, I mean, as the data show, you can give it in CR or PR or stable disease. And I think an important note in urothelial cancer is that patients do have high rates of progression, even in the setting of that complete response. As far as the durability of use, we have the 2 years on the clinical trial. And I use a bit more of a risk-adaptive approach. If they're on their maintenance avelumab and they're in CR or they go into a CR, then I usually stop after 2 years to give them that break. Yet if they still only have that partial response and there's active disease remaining, those are the ones I worry about more, and I'm more inclined to continue the checkpoint inhibitor longer in that patient. Now, I don't have data to support doing this, just the knowledge that a lot of patients do ultimately progress from their urothelial cancer. We're still not curing most patients.
Yep, and I think that message is loud and clear. We're going to learn a little bit more in your talk in just a second, but I think we have more cases coming from our physicians asking about their patients.
Dr. Priya Rudolph has an interesting approach to the use of antibody-drug conjugates in metastatic urothelial bladder cancer, as demonstrated by a 65-year-old man in her practice.
He's already burned through cis-gem combination. He was on a brief avelumab maintenance and then switched to sacituzumab upon progression. And should he progress on sacituzumab, I can use enfortumab. However, I've had patients with significant side effects with the drug, just tolerance issues, anything from neuropathy to severe fatigue in most patients. He does not have any actionable mutations.
It's interesting. Is that your general algorithm at this point? Sacituzumab first, then enfortumab?
That is correct. Sacituzumab has been a godsend in triple-negative breast and bladder and works extremely well for these patients.
How many times have you used it in bladder?
Twice so far, and very good responses. I've used it in a whole bunch of breast cancer patients, triple-negative and hormone receptor positive breast cancer.
Dr. Rudolph has reversed the usual sequence of antibody-drug conjugate therapies in the adjuvant setting. Do you have any thoughts about this? Is there data to support it? Would you do the same thing? What is your experience with sacituzumab? What about enfortumab vedotin?
All wonderful questions. Matt, we've talked a lot about what we're doing sort of frontline. Thoughts on EV versus SG?
So we have level 1 evidence for EV, a survival benefit in a randomized phase 3 study. We have a similarly designed study with sacituzumab that's completed accrual and that hasn't read out yet. So the level of evidence is higher for enfortumab, and that's what I tend to use first. But the toxicity profiles are non-overlapping, and I think it's a very interesting demonstration of a clinician's initial experience with the drug can certainly shape how they use it in the future, and that might be completely based on luck in terms of what happens in that individual patient. But my algorithm tends to be reverse, but certainly for some patients for whom you're concerned about the toxicity profile of EV, starting with sacituzumab certainly makes sense.
No, that's great. And Jonathan, did you want to clarify maybe that although they're both antibody drug conjugates, they're actually pretty different?
Right, so they have different targets, different linkers, and different cytotoxics. And so the spectrum of side effects and the spectrum of probably of activity aren't identical. And I, like Matt, tend to use enfortumab vedotin first. Although I will say I do find, with rare exceptions, sacituzumab is pretty well tolerated, except perhaps in patients who have Gilbert syndrome, where I've seen and heard about some patients with more severe toxicity.
Yeah, absolutely. And Arlene, I'll have you say the last word. What's your optimal sequence here?
So like Jonathan and Matt, I do tend to use enfortumab vedotin first. I find that it works quite well, especially in patients with bone metastases. So it has quite a bit of activity when you have that bone met phenotype. The toxicities are clearly different. Patients who have both often tell me that the sacituzumab feels a bit more like chemotherapy. They have more of the neutropenic fever, more of that diarrhea and severe fatigue. In fact, because of the neutropenia and neutropenic fever, in my bladder patient population, I've chosen to give growth factor support prophylactically in patients receiving this due to the higher rate of neutropenic fever. It may also be reflected in that we're tending to use it more third line, possibly fourth line, depending on if you gave a second line immune checkpoint inhibitor or had erdafitinib thrown into the mix. So I do tend to use enfortumab vedotin first, but I think on the basis of toxicity, patient with severe neuropathy, you might reach for sacituzumab govitecan before enfortumab.
Well, I think the interesting thing is, there's data out there that says that although we've got all these great trials, patients are still struggling getting, second, third line and so on therapy. So I think the sequencing issue will certainly continue on, and we'll hear from that from you as well. Let's move on to the next physician video.
Dr. Yanjun Ma is providing care to a 65-year-old man with de novo metastatic urothelial bladder cancer.
This is a patient who had urothelial renal pelvis, stage 4 disease de novo, and had upfront carbogemzar, moderate response, progressed pretty quickly after finished. We move on to pembro single agent for second line. He had a great response now. He does have a FGFR3 mutation. So if he does progress after pembro, these later line options for bladder cancer coming out is very confusing to me. So what about erdafitinib for FGFR3 mutation or enfortumab, the drug conjugate? How do you choose in this setting? Because I have no experience using these agents yet. I'm not sure about the side effect profile to dictate what to do for patients like that. I'm just curious of panelists' opinion on that.
So the question in this case is, what is your third-line systemic treatment beyond combination chemotherapy and immunotherapy in metastatic urothelial bladder cancer in a patient with an FGFR3 mutation, and how do you optimize patient tolerance with the use of erdafitinib?
Now we're getting complicated because now we're throwing in more medications. Matt, what is your approach to handle erdafitinib in patients with FGFR3 alterations?
So I would generally use it next. There is always the discussion about moving to an antibody-drug conjugate versus using erdafitinib, a small molecule inhibitor of FGFR in this situation. But I find that patients, they've received sequential treatments with intravenous therapy coming into the infusion unit, giving an oral therapy in this situation, I often see as a welcome break from those infusion visits.
Yeah, Jonathan, I think she was maybe not 100% clear on perhaps the toxicity profile, but just what should we be on the lookout for with patients getting treated with erdafitinib, just in your experience?
There's a few things you have to watch out for. So hyperphosphatemia is something that requires dose adjustments, either dose escalation if it doesn't really occur, or dose reduction if it gets super high. Fingernail toxicity, mucositis are all things that I found to be difficult to manage, and sometimes patients have a hard time with poor nutritional status after they've been on it for a while because they feel like they can't eat despite maximal management. But it's a very active drug, and I think I think as investigators, we're hoping we're going to see less toxic, as effective FGFR inhibitors in the future.
Arlene, any problems getting an oral medication covered in your practice? All the drugs we've been talking about primarily have been intravenous.
Sure.
Thoughts on that?
Well, it can be challenging for some people with their insurance plans whether oral medications are covered. And it also takes a little bit of time. You have to go through the process, get assurance approval, submit the forms, wait for the drug to be shipped before the patient can start treatment. But despite that, it is a very effective cytoreducing agent with a 40% objective response rate and at least 70% of patients having some reduction in the size of their tumors. So it is a good drug to cytoreduce and improve pain. Now, toxicity is always an issue, and I always encourage patients to start on a low phosphorus diet. Then at day 14, it has this up titration to try to optimize the dose from 8 milligrams to 9 milligrams. I look at it as an induction maintenance strategy, trying to get to the appropriate dose to induce a response. But then if you have to dose reduce over time to help maintain the response, even that lower dose of 8 milligrams or even down to 6 milligrams can help maintain the dose or maintain the response that you've already achieved. As far as the other toxicities, like the paronychias and onycholysis or hand-foot syndrome that can also occur, most patients do need a break on treatment after they've had about 2 to 3 months of therapy. My patient who was on it the longest, about 3 years, about every 2.5 to 3 months, he would require a 2-week break, allow some wound healing to occur on the hands, and could then go back on the same dose and had long-term control of his urothelial cancer by doing these intermittent dose interruptions.
Those are really practical suggestions I think we all should pay heed to. Why don't you go ahead and tell us more about additional options for this group of patients?
Oh, thank you very much, Elisabeth. And as we know, you're hearing about multiple targets, targeted therapies, and what is involved in choosing a good target. We've heard about PD-L1, but it's not used a lot. Possibly because of the reproducibility issue and the fact that different therapies can induce PD-L1 expression and may obscure some of the benefit. We have seen multiple targets, though, that are easily reproducible, CLIA certified. Some of them you don't even need to test for the target, like TROP2 or Nectin-4 expression. And we're seeing very good responses in these therapies that are targeting specific targets on urothelial tumors. We've heard about enfortumab vedotin, which was the first antibody drug conjugate approved in urothelial cancer. This has a cleavable linker. It targets Nectin-4, which is found on over 90% of urothelial tumors. You do not need to test for Nectin-4 expression. It brings the toxic payload of monomethylauristatin E directly to the tumor, and only when it's taken up in the tumor is it cleaved from the antibody, releasing active drug. It's a very potent tubule agent, which is why it could not be given systemically when it was first developed over 15 years ago. When we look at the phase 3 trial data, we have level 1 evidence in a group of patients who had prior chemotherapy and prior immunotherapy who were randomized between enfortumab vedotin and a pre-selected single agent, either a taxane or vinflunine in Europe. And as we saw from the early results, or the first results from this trial, we saw an improvement in response rate with an objective response rate of around 41%, and chemotherapy arm only having about an 18% objective response rate. And that translated to benefit with overall survival of around 12.8 months compared to about 8.9 months with chemotherapy alone. More recent updated data confirms that these findings remain relevant and remain persistent, with a median overall survival now of 12.9 months, chemotherapy again, 8.9 months. So clearly, enfortumab vedotin is a very good option. It improves survival compared to single-agent therapy. However, it does come at the risk of toxicity. It's a tubule agent. We see neuropathy, especially in patients who are continuing on long-term treatment with enfortumab vedotin. We also see this rash that can occur and hyperglycemia. And if a glucose goes above 250, did you know you're supposed to hold the dose of enfortumab vedotin? I think it can be a sign that you're having too strong of tubule inhibition, and we're seeing that by decreased uptake of glucose in muscles due to inhibition of all of those tubules. As far as the skin reaction, a lot of patients can develop more of this papular, macular type rash, but when it becomes more diffuse, often you'll see a little beefy red appearance, or if you see any peeling of the skin or bullae formation, you need to hold the dose of treatment. In fact, there's a black box warning about Stevens-Johnson syndrome. However, I don't think Stevens-Johnson is really the best way of classifying this. I think it's due to targeting of Nectin-4 expression, which is found in skin. And I've seen this occur most commonly in patients who have cirrhotic livers or are found later to have some type of fatty infiltration comprising liver function. So as far as the toxicity profile, you need to be very cautious in a patient with liver dysfunction. It's mostly recovered, or it's mostly excreted by the liver. If there's renal impairment, you do not need to really adjust the dose. But if there's liver impairment, you definitely need to be very cautious. And I would avoid use of this drug in patients with a Child-Pugh score B or C, or if you are going to give it with a dose reduction up front, because those cirrhotic livers, it's cleared mostly by the biliary tree. You'll end up with excess tubule that will contribute to this diabetic ketoacidosis with insulin resistance, targeting of the skin, diarrhea. I've even seen rhabdomyolysis. So watch out for livers. And hold parameters, glucose above 250, which could be a sign you're inhibiting tubules, and I think it reflects uptake in the muscles. The muscles are the biggest utilizer of body glucose every day. Over 75% of glucose is consumed by our muscles. And if the person has any peeling of the skin, you might see this on surfaces that rub, the dorsum of the foot, under the arms. They should definitely hold the dose, or grade 3 diarrhea. Another drug that's targeting is erdafitinib, which is the first FGFR3 targeted therapy that was approved in urothelial cancer. We saw the early data that came out of this drug that is a pan-FGF1 through 4 inhibitor, and saw early clinical activity in FGF-altered tumors, including cholangiocarcinoma and urothelial cancer. When the trial was designed, we did not yet have an oral therapy that could be given continuously. all of the oral FGF inhibitors had been given intermittently, mostly due to toxicity. But intriguingly, some of that intermittent dosing may contribute to more of the hyperphosphatemia that was observed with those therapies. Because as a patient receives continuous inhibition with erdafitinib, over time, those phosphorus levels which go up, homeostatic mechanisms kick in inside the kidney, resulting in an excretion of phosphorus, and the phosphate levels come down. When we saw early results from this clinical trial, there was a 40% objective response rate, with 76% of patients having at least some reduction in the size of their tumor, and this resulted in the FDA accelerated approval of erdafitinib. We also saw promising overall survival and progression-free survival that at update was around 11.3 months overall survival, with a progression-free survival again around 5.5 months. But it does have special toxicities for which we should be aware. That hyperphosphatemia, which I typically manage with a low phosphorus diet, and about the time the patient is tired of following the low phosphorus diet, about 5 to 6 weeks later, those homeostatic mechanisms are kicking in. They're starting to excrete more via the kidneys. You can see those mouth sores, that dry eye, the hand-foot syndrome, encouraging patients to use emollient creams. The creams in a tub helps protect the skin and will help keep it from drying and cracking, and I believe will help them stay on treatment a bit longer than if they do no skin care. Another thing to watch for is central serous retinopathy, which is associated with other inhibitors of the MEK and MAP kinase pathways and is typically managed by dose holds, with most patients able to resume treatment at a lower dose. We also have a second antibody-drug conjugate, sacituzumab govitecan, which now has accelerated approval in urothelial carcinoma. This is another antibody, but it targets TROP2 expression, which again is found on over 80% of urothelial cancer samples, so you do not need to test for TROP2 expression. So of these three targets, the one you need to test for is FGFR3. You don't need to test for Nectin-4 or TROP2. This brings the target, SN38, or irinotecan, directly to the tumor. It's a hydrolyzable linker, so it's removed mostly in the cell, but because it's hydrolyzable, there may be some removal of this in the circulation, accounting for some of its systemic toxicity. Response rates also looked very promising with sacituzumab govitecan, with about a 27% objective response rate, which translated to a median overall survival of around 10.9 months. But it does have toxicity. Much like irinotecan, we see that hematologic toxicity, neutropenia, neutropenic fevers. And in my elderly bladder patient population, especially since they're pre-treated fairly heavily with prior chemo, IO, and EV, I have chosen to give prophylactic growth factor support on these patients. We also see a fair amount of diarrhea and GI upset that can occur as well. And patients do say, compared to these three targeted therapies, that sacituzumab feels a bit more like chemotherapy, or how they felt when they were undergoing prior chemotherapy. But as we see, when we have single agents that look too good or look like they're doing well, we want to make them better. So we're going to combine two great agents together, like peanut butter and chocolate, hoping for that FDA or EAU approval. Arguably, is Nutella that much more nutritious? Hard to say. But we saw some of the early data with enfortumab vedotin plus pembrolizumab showing this exceptional objective response rate of around 73%, with durable responses and durable survival that we hope to see pan out in the larger phase 3 trials. We also have the Norse data combining FGFR3 inhibitors and erdafitinib with the Janssen PD-L1 inhibitor citrilimab, which is also showing promising objective response rates. And one of the ideas behind this combination is that the FGF-altered tumor is immunologically cold, and by giving the two agents together, we can induce a better immune response and hopefully control that tumor much better. We also saw sacituzumab govitecan combined with an immune checkpoint inhibitor. However, response rates were not as promising. We see a 34% objective response rate, which arguably is pretty similar to the response rate that was observed with the single agent. Now, why is that? Well, sacituzumab is very myelosuppressive and it induces a lot of lymphopenia, so perhaps you cannot induce the immune response one would hope for, as you've now eradicated the lymphocytes with sacituzumab. So we have multiple new drugs targeting multiple new targets, clinical activity with each, and specific toxicities of each, and the potential for combinations that might also be transforming the paradigm as to how we are sequencing therapies for our urothelial cancer patients. And I'll thank you all for your time.
Thank you so much, Arlene. That was fantastic. I know we had some audience questions that were mostly about handling cytopenias and side effects, but I think your take-home point is these drugs are all great as long as we know how to use them properly, and to be careful. And there's guidelines in the package insert, so I think there's enough information out there for those of us in practice having to deal with this that we can rely on. So thank you for pointing out the ones that we need to be mindful of. You know, I think the next question is always, well, we're doing all that. What else is on the horizon? So in our last module, it's really to look at what's coming down the pike and what are some of those potential agents. But let's hear from our next physician about his case.
Dr. Georges Ozzie took a somewhat controversial approach to managing a 67-year-old man in extremely poor condition.
This 67-year-old man, HIV positive, history of hypertension with CKD4, diagnosed with urothelial carcinoma secondary to hematuria. Workup revealed urothelial carcinoma with mets to retroperitoneal lymph nodes and bones. His performance status when he saw us was 2. So I didn't think he was candidate, obviously, for cisplatin, but not even any platinum-based chemotherapy. So based on the EV Pembro data, I did submit an appeal, and that got approved to start him on the EV Pembro regimen. And he's tolerating it well and is having a partial response now.
Any questions you'd like to see the faculty discuss about this case or about EV Pembro?
How would they approach the dosing of the EV? Incidentally, this patient tolerated at the 1.25 milligram per kilogram pretty well, but I've had other patients who tolerate that very poorly. Skin rash, hyperglycemia, just fatigue in general.
Dr. Ozzie would like input on the dosing of enfortumab and tolerance issues, and would also be interested to hear the faculty's view on the choice of therapy taken here, which in reality was combining the next 2 lines of therapy the patient was likely to receive.
So how about that, Jonathan? He just went for it. I'm not sure if the rest of us would actually get that approved, but for this patient, it certainly was possible. What are your thoughts on sort of doing that approach in practice?
I think we're going to likely see an accelerated approval for cisplatin-ineligible patients very soon. So hopefully the insurance issues will be less of an issue. You know, many patients who are platinum ineligible from, you know, their disease is making them ineligible for treatment, and really what you need to do is treat the disease. And so therefore, if that's really what was going on, this was a very reasonable choice of action here. But I do feel that, you know, truly platinum ineligible, frail, very elderly patients may not be great people to get enfortumab and pembrolizumab, or at least think about starting at a marked dose reduction of the enfortumab. And managing toxicity of enfortumab is, I think, something that you get a sense for over time with dose interruptions, and dose reductions are able to help with a lot of toxicities in the short term. The data for EV Pembro with reduced doses really doesn't exist yet. We'll have to see as we get more dose intensity data from the trials.
Yeah, and Matt, I think you were on a panel today, really thoughtful about maximizing supportive care and really leveraging the team. I mean, is this the type of patient that maybe shouldn't have any treatment at all?
So I think discussing the risk versus benefits of any treatment in every line of therapy for metastatic urothelial cancer is appropriate. I find that having those discussions, though, in the untreated setting, it's an unusual patient who will opt not to proceed with treatment. And as you saw from the quality of life data presented by Matt Malowski with EV Pembro, there's a pretty marked palliative benefit, particularly with pain, that happens quite quickly. And so I think even for symptom improvement, there's rationale to proceed with this regimen.
Sounds great. I think we'll move on to the next physician question.
So, two very different and fascinating cases of metastatic urothelial cancer. The first, a 75-year-old man who's a patient of Dr. Victoria Giffey.
He was diagnosed with a bladder cancer that had a mixed histology, both urothelial and small cell. He had been at Camp Lejeune for a number of years, and we assumed this was why he got it. He was never a smoker. He received concurrent chemoradiation with cisplatin and etoposide. Only about 5.5 months later, he developed worsening low back pain and in his sacrum as well, and was found to have osseous metastases and bilateral pathologic fractures of his pubic rami. Because he was a bit frail by that point, had lost some weight, had a lot of pain, wasn't moving around, we actually decided to just start pembrolizumab just to see what would happen. It was all we thought he could tolerate at the time, and we considered his disease platinum refractory. And his pain went away within a month or two. He's been in a complete remission for 5 years this month. So he's now 81 and still very active and remains on pembrolizumab.
The other interesting case is a 50-year-old man who's a patient of Dr. Laurie Matt-Amaral. How did he present?
Abdominal pain and actually some difficulty with urination. I believe he also had hematuria as well.
I must have been surprised to see that it was small cell.
I was very surprised, and so was the urologist who did the surgery. He actually was found to have small cell bladder carcinoma, metastatic disease to the peritoneum and the abdomen. So he was treated with a small cell regimen using cisplatin, etoposide, and durvalumab. He responded really well to all 6 cycles. He has actually been maintained on durvalumab for about 1.5 years now, and he's actually doing really well.
So any questions about his case?
Do they think durvalumab was an appropriate choice? Would they have chosen atezolizumab in this case, even though it's not necessarily a lung?
So the questions for these two cases are, first, the seemingly age-old question of when to stop an IO in a patient responding and doing well, and of even greater importance, what have we learned about super responders to IOs? And second, how do you manage small cell carcinoma of the bladder?
Oh boy, Arlene, I'm going to toss the small cell one to you. We've all talked tonight about transitional and urothelial traditional type of subtypes, but we know that that's never the case in bladder cancer, always a curveball. Thoughts on small cell?
Sure. So when we see a small cell urothelial cancer patient, if we see a patient who's surgically resectable, we start with neoadjuvant chemotherapy, and we've published on this alternating regimen of ifosfamide adriamycin with etoposide cisplatin with a phase 2 clinical trial showing that we can cure substantial numbers with chemotherapy and surgery. If a patient is not a candidate for surgery, I would consolidate with radiation. I personally believe the benefits we've seen with the surgical approach likely reflect the carcinoma in situ that's commonly found with small cell tumors and may be a contribution to the higher risk of recurrences that has been reported in the radiation literature. When we have a patient with metastatic disease, I typically treat again with the alternating regimen. If they can't tolerate ifosdoxorubicin, I do etoposide cisplatin alone. And then I have been following that with immune checkpoint inhibition, since small cell tumors that are metastatic tend to metastasize or recur quickly and be highly chemorefractory at that point. Now, seeing these phenomenal responders, we certainly see them as well. I have a patient who progressed on their frontline treatment. First 2 cycles responded, second 2 cycles progressed in liver. Those patients are usually dead within 6 weeks in the era of chemotherapy alone. And we enrolled that patient on a trial of Nivo-Ipi and saw a phenomenal response in the liver that is durable now for about 4 years. So these phenomenal responders do exist. We don't quite understand completely why some people respond better than others. I certainly have plenty of small cell patients who have not had the phenomenal or dramatic response, but I do believe checkpoint inhibitors work. I don't believe it's limited to atezolizumab, and in fact, in urothelial cancer, where we don't have an atezolizumab second-line indication, we have found it very easy to get Pembro or Nivo or one of the other checkpoints. So I don't think it matters using atezolizumab versus Pembro or one of the others.
Yeah, no, that's great. And Matt, I mean, would you, and I'm going to go there, would you check minimal residual disease status to help you feel better that you are now a true extraordinary responder?
Not in this context. I mean, I think it has an emerging role in the postoperative setting, and certainly we need to establish clinical utility for that, but I haven't been routinely assessing molecular residual disease in the metastatic setting in my practice, but certainly there is Medicare coverage for immunotherapy monitoring, which is a pretty broad sort of indication.
Thank you so much. And I think that, that was an audience question as well. In urothelial cancer, just like in every other GU tumor, we want to know what are some of the markers that's coming up. So certainly important. I think that the future looks quite bright. And, what's exciting for those of us who do drug development is that what you've heard tonight are all mostly FDA approved, and we're just sort of figuring out combinations and strategies. But what else is coming down the pike are additional targets. So one of those is another antibody drug conjugate, so disitamab vedotin, but the target here is HER2. So no, this is not a breast cancer talk. It's still bladder cancer. But I think, even many moons ago when HER2 was a target that was investigated, this is sort of the newer generation approach. So be on the lookout. And I think what I'd like to do is just run through these slides so you can be familiar, especially when you attend meetings and you're reading abstracts and so on about what's coming. It's interesting when you're looking at the fanciness of HER2, because those of you who treat a lot of bladder cancer certainly know that that target has been well investigated and studied. Here, this was a compound that was looked at initially in phase 2, and we were starting to see images like this and curves with really remarkable responses and improvements in liver metastases. So this particular agent actually received Fast Track designation in 2020, but it's of interest because we were hung up a while ago about how do you know what the target is? So not so much as Arlene was alluding to that we needed to check Nectin-4 or TROP2. Here it's just regular immunohistochemistry. And you can see all the different colors, whether you're a 2+ or a 3+. That's a downward below the line there, sort of. So that shows a lot of interesting activity. And last year at ASCO, there was, again, more data being shared where here there was another trial with just slightly different eligibility coming in for these patients with HER2 positivity. And the data is really starting to look as promising as a lot of the other compounds you were seeing tonight. These are all, though, patients that have had 2+ or 3+ IHC for the HER2 status. And if you're sort of thinking about, well, does that matter? Well, if you're looking at this after first-line chemotherapy, it's certainly looking intriguing with a median OS of 14.2 months. But then comes the question of what if you express no HER2? And this, again, in the breast cancer world has come up, whether the test is actually adequate to test whether it's truly HER2 negative. And in this particular report, it actually does show that For the most part, I think the 1+ers are sort of ideal. There's still a couple of patients here that are showing some responses for the zeros, but I think these are areas that will continue to be evaluated because you almost don't want to leave anyone behind depending on what their status is. So I show this just to get you guys interested in this particular target because it's not something that has become sort of so clear in our mainstream. The trastuzumab deruxtecan, which I just call TD, many of you already also are familiar with, are now being evaluated in combination with nivolumab. So again, just as what our panel was saying, you know, all these drugs, whether it's single agent or in combination, are being evaluated. And it's interesting because when you're starting to see numbers like there's a CR rate here in the second line that have a also intriguing PR and so on, there's some activity. So I think in the days in the beginning when before we started to really get some of these drugs that have interesting payloads, we were getting almost no responses except for chemotherapy. So it's exciting to see the next sort of batch of drugs coming down with also similar type of numbers. And since we've been pretty stuck on PARP inhibitors in the prostate world at this meeting, the bladder world is not to be left behind. I think that many of us who do a lot of sequencing and molecular profiling also recognize that the DDR or the HRR mutated patients are also something that's being seen in the bladder world. There are trials here that I've listed in case you're interested to really show the depth here of how PARPs are being investigated. So you are not looking at a slide for prostate cancer, you're actually looking at a slide for urothelial cancer. I'd like to highlight one of them, which is the Bayou trial, which I think, Jonathan, you were alluding to their control arm here, but this is durvalumab plus olaparib in previously untreated platinum-ineligible patients, and was really, I think, showing some interesting data, but this is results in an HRR mutated population, as you can see on the right side of the graph. So obviously, in the interest of time, we can't get too deep into this, but just be on the lookout as PARPs are also in the clinical trials world for your advanced bladder cancer patients. And we've heard a lot also tonight about erdafitinib and the FGFR pathway being targeted. Well, there are many more where that's coming. So we have regorafenib, which is a pan FGFR 1 to 4, infigratinib, which is also in treatment as well in the adjuvant setting. So interesting sort of approach there where it's not even just in the metastatic setting, all again requiring alterations of this particular gene. There's another one, pemigatinib, futibatinib. So I'm just going to nib all the way around, but what does that show? It's an interesting area. Now, for the amount of patients with the mutation, I think we're all going to have to get kind of smart about how many of these we can really squish in. But I think for your patients that you can enroll, it would be really great to further this area along. And we've heard tonight about the Checkmate data, which really sort of started this whole, wow, immunotherapy, especially in combination, is maybe the way to go. But is it the way to go? So I think, Jonathan, you mentioned the Keynote study, which was already, I think, published in 2021, not positive. Here last year, this also showed that this particular frontline is not the results that we wanted. I'm not aware that the Nile study, again, evaluations of durva in combination, I don't think that's been read out just yet. But you look at Danube, and this unfortunately also met an endpoint that is not what they had wanted. And it's not just exclusive to immunotherapy plus chemo. Here's a combination with pembro and levantinib, another VEGF. So the take home here is that although we love combos, don't just think they're all going to work because they're sort of not all working. So this really needs to be done with some thoughtful manner. Not to be outdone in the world of combinations is cabozantinib. no, this is not a renal cancer slide. This is a bladder cancer slide. So same thing, multiple combinations. I think the data here is really still emerging. Again, there's some more work that needs to be done to understand the toxicity to make sure we're not over-treating patients. Another tyrosine kinase that's getting a lot of airtime is sitravatinib. This targets a different family of receptors, multiple cohorts, so also be on the lookout. Sometimes it gets really confusing, but when you have studies that have about, anywhere from 8 to 10 cohorts constantly evolving, you can figure out why we're all a little bit confused. But these are some of the curves that are looking familiar and ones that we actually are demanding, I think, for our patients. And what's really clear is that the targets are still there, whether it's HER2, more HRR mutation, more FGFRs, understanding whether we're looking at ctDNA, biomarkers, or just standard immunohistochemistry. We just need to really pay attention and try to enroll your patients in clinical studies so we can really advance care. I think that is actually the end of our session tonight. I'd like to thank everyone for attending this particular symposium, and of course for Neil Love for hosting it. I really want to thank all of my colleagues here tonight, Matt, Jonathan, and Arlene, for your wonderful expertise and knowledge that you're sharing with our audience. And I'd like to also thank all of you that's in front of us live here today, as well as those of you joining us on the webinar. And thank you to the physicians who also shared their real-life cases with us. Thank you so much for being here tonight, and have a good evening.